Okay. All right, everybody. Good morning and welcome to our Sweatland seminar series for September. It is a pleasure to have everyone here with us today. So we will go ahead and get started. Just a little bit of introductions and housekeepings before we get into the presentation. So please, like I said before, mute your audio, or if you're just joining now, please make sure that your audio is muted. If you do have a question or a comment, feel free to use the chat function. I will be monitoring the chat throughout the presentation. So if we have any questions for the presenters, I'll be sure to help moderate that and make sure those get to our speakers today. And in the meantime, please feel free to share your name as well as your organization that you are representing in the chat box. We can see who all we have here on the call with us this morning. Before we get started with our presentation today, I do just want to talk about our upcoming seminar for October. So next month, the Sweatland Center will be virtually hosting two national speakers, Dr. Shenandoah Billiot, who is an assistant professor at Arizona State University's School of Social Work, as well as Dr. Meredith C.F. Powers, assistant professor in the Department of Social Work at UNC Greensboro. So Dr. Billiot and Dr. Powers will be presenting at our usual seminar time slot next month at 9 a.m. from 9 to 10 on October 26th. And then during that time, they're going to be discussing sustainable approaches to addressing environmental, economic, and racial injustices using an eco-social worldview. So we invite you to join us for that seminar. And then in addition to our normal 1-hour seminar time slot, our speakers will also be hosting a training consultation session following the seminar from 10:30 that morning until noon. And during this training consultation, we will be exploring both current and historical environmental health concerns and injustices at the intersection of racial and economic justice. So our speakers, Dr. Billiot and Dr. Powers, will be offering suggestions during this training consultation on embracing an eco-social worldview and applying it to teaching, research, practice, and policy changes. So we invite you to join us for both the seminar and the training consultation. Both will be hosted virtually and are open to the public. And once we get started, I will go ahead and put the link to the event page for this in the chat box if you're interested in learning more about our speakers and registering for these events. Okay, so I am delighted to introduce our three presenters for today's seminars. They are all trainees of the Sweatland Center. So we have Kyung Lee, who is a postdoctoral scholar here at Sweatland. She received her PhD in environmental health sciences from the University at Albany, State University of New York. Her dissertation work examined the environmental impacts associated with crop production in the US Midwest, as well as examining respiratory effects associated with living in close proximity to biorefinery facilities in New York State. Gwendolyn Donley is a PhD candidate in epidemiology and biostatistics at Case's Department of Population and Quantitative Health Sciences, and she's a predoctoral scholar on the Foodnest 2.0 study here at Sweatland. Her dissertation work examines housing instability and food environments in historically redlined neighborhoods, as well as the experiences of Black pregnant women with vaccines and healthcare during the COVID-19 pandemic. And India Gill is also a PhD candidate in the epidemiology and biostatistics at Case's Department of Population and Quantitative Health Sciences. And she's also a predoctoral scholar on the Foodnest 2.0 study. India provides support to our center's community engagement and racial equity assessment efforts as well. Her dissertation work is a geospatial study that explores how the history of structural racism and redlining influences differential neighborhood level risk factors for child asthma exacerbations. So today, our three Sweatland trainees will be presenting on health outcomes in redline versus non-redline neighborhoods. And lastly, before we get started, I'd also like to mention that we are seeking your feedback about our Sweatland seminar series. So I will be putting a link to a brief survey in the chat box, which we invite you to fill out at the end of the seminar. We're just seeking feedback on the type of presentations you all are interested in seeing and listening to, any recommendations for future speakers that we can bring, and any suggestions that you may have for our Sweatland Readers Book Club. So any book suggestions, we are taking feedback for that as well for next year. So I will be putting the link to that in the chat box as well. So I will go ahead and stop sharing my screen, and I invite our speakers to go ahead and share their presentation. Thank you.
All right, thank you so much, Lindsay, for introducing us and for that nice introduction. Now I'm going to share screens. Apologize beforehand if my internet is a little slow, but hopefully you are seeing my slides now. Great.
We're seeing the notes mode, not the presentation mode.
Yep. Sorry, my computer is a little slow, but there we go. Great. Well, thank you so much again.
On Kyung. Oh, there you go. Perfect.
Yeah, my computer is a little slow this morning, acting up. But yeah, thank you so much again, everyone, for attending this seminar. Today, we are delighted to be presenting recent research in neighborhood inequality, present some background on redlining neighborhoods, as well as some results of a systematic review and meta-analysis that we conducted on health outcomes associated with living in redlining neighborhoods. So before we start this seminar and to get you oriented to today's talk, we would like to start with asking by a couple of questions. And Gwen will be sharing a link in the chat. And there, if you could please just share with us what comes to mind when you hear the following words. Neighborhood inequality. So Gwen put a chat in the link for poll everywhere. And if the link doesn't work, please just copy and paste the link to your browser directly. We'll give about 1 minute for you to respond. What comes to your mind when you hear the following words? Neighborhood inequality. So we are seeing some responses here. We see primarily racism, redlining, resources. So the bigger words are, the more people responded. Redlining, racism, resources, environmental segregation, inequality, disinvestment. Great. Thank you so much for your responses. We're gonna stop receiving responses. And secondly, one more question. If you could also share, using the same link, if you could also share what comes to mind, or who do you think would be affected the most by neighborhood inequality? And same thing, using the same link. If you could share, who do you think is affected the most by neighborhood inequality?
The poll is still locked, I think.
The poll is locked, okay. Just 1 second.
The poll is still locked. Okay, now it's not.
Again, one more time for me. There we go. So now I'm seeing responses of minorities, marginalized children, Black color, and these are responses for who do you think are the most affected by neighborhood inequality. I see minorities, a lot of low marginalized, impoverished. Thank you so much all for your responses. And I'm going to now close the poll or the word cloud. Great, thank you. And just like as you might mentioned, and just like you shared, we know by common sense that neighborhood inequality affects us as well as others, and particularly the most vulnerable populations. There is extensive research that shows that inequality affects everybody, particularly the most vulnerable populations, including children, because they are on their development as well as their elderly population, by shortening the life expectancy. According to US Census in 2019, almost 12 million children, 1 in 6, lived in poverty, and almost 5 million adults ages 65 and older lived in poverty. And poverty is a significant indicator of inequality in terms of socioeconomic status. According to Ash and colleagues, they found that both whites and minorities experience higher exposure to air pollutants among those who live in more segregated metropolitan areas compared to those who live in less segregated metropolitan areas. In the graph on the left side, you will see higher exposure to air concentrations among those who live in highly segregated areas in lighter gray, and less exposure to air pollution in less segregated areas represented in darker gray or black, in both predominantly minority and white neighborhoods. As pertains to disparities in environmental exposures, racial segregation in US metropolitan areas have also been associated with disparities in health outcomes, including cancer. The map on the left, developed by Morello Frosch and Gisdell, shows the extremely segregated areas in the US, represented by red, and to less segregated areas represented by yellow or lighter colors. You can see that in Cleveland, as well as towards the east side of the US, are more segregated than towards the west side of the US. And this highly segregated and extremely segregated areas have been associated with 4 to 32 times increased risk for cancer. And this is particularly true for Asians, Pacific Islanders, Hispanics, and Blacks in that order, although it affects everybody or all racial groups. Jorgensen and colleagues have also show that inequality is bad for the environment. They quantify that income inequality is associated with increases in carbon dioxide emissions across all 50 states, including DC. And on the graphs in the bottom 2 graphs show some positive correlations or positive trends of income or income indicators represented by Gini coefficient or index, with increases in CO2 emissions. So this means that more income or more wealth increases CO2 emissions seen throughout the US or throughout all 50 states of the US. There are 3 ways that Cushing and colleagues explain how this social inequality or neighborhood inequality affects or degrades the environment. Or more wealth have greater voice in what goes into the decision making, or even those who are doing the research or funding the research have greater voice on the decision making. Sometimes industries like oil or gas industries fund research that are related to air pollution, so there is some conflict of interest, and those who are affected the most, for example, people who are living in near industry areas have less voice in the decision making, therefore being affected more by this air pollution or pollution overall. Secondly, social inequality or neighborhood inequality affects the environment by increasing consumption. Cushing and et al. Discussed that more racially segregated neighborhoods or socioeconomically segregated neighborhoods, there is this prevalence effect, which explains behaviors of consumerism influenced by inequality, meaning that people who see more wealth or more possessions that people like to have, because of that, they consume more. So people see, cars or houses or people traveling, they want to emulate that. So people consume more, increasing more use of resources and more emissions, therefore, and more work hours as well. And lastly, racial segregation or segregation overall disrupts social cohesion, cooperation, and trust. So research shows that more racially segregated areas tend to cooperate less to protect common resources and are likely to be less interested in environmentally sustainable practices like commuting together or sharing common space, which leads to more use of resources as well as emissions. It is true, and you've mentioned that people of color are still being affected more and are more likely to be affected than white counterparts because they live near polluting areas or polluting industries, near farms, hog farms, live near chemical disaster or climate vulnerable areas like flooding areas, as well as areas that do not meet air quality standards. And more racially segregated areas also experience significant health disparities because of poor air quality, water quality, as well as lack of amenities such as green space. So inequality exists everywhere. It affects everybody. However, it continues to affect more people of color and the most vulnerable populations like children and elderly populations. And to able to achieve or address this inequality or equity, it will require us to have more efforts or shift in the dynamics of how we address. And just reading the definition of environmental justice, it says that it's a fair to achieve environmental justice. It's a fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policies. So it will require a little bit of more effort for us to achieve or address. Now I'm going to turn to my colleague Gwen, who will explain more about the historical context that are explaining these inequalities and disparities in the neighborhoods.
Thanks, Kyung. So next slide, thank you. So there are a lot of historical practices and policies that have helped sort of create the disparities that we see now in the built environment, infrastructure, and amenities and disamenities that influence racial segregation as well as health outcomes. So as many of you are aware, redlining was a practice that was first enacted in the 1930s across the United States. So with the Great Depression, the New Deal was enacted in 1933 to help ameliorate that financial crisis. Through the Federal Housing Administration, the government sponsored the Homeowners Loan Corporation, or the HOLC, to avoid default on loan repayments. The HOLC assigned grades and color codes from A to D based on housing conditions, surrounding neighborhoods, and existing racial and ethnic composition of those areas. A was the best grade and was coded with green, while D was the worst grade and coded with red, hence redlining. This practice very effectively barred people of color from obtaining loans and mortgages or from moving to other non-redlined neighborhoods. And in the 1960s, the Fair Housing Act outlawed discriminatory housing practices, but we see that the effects of redlining still persist today. Next slide. Thank you. So redlining has many consequences, as we'll continue to discuss in today's talk. So For example, more multifamily houses were placed in redline neighborhoods. Redline neighborhoods were in closer proximity to industrial facilities, major highways, and landfills. Redlined areas also experienced neighborhood disinvestment with more vacant spaces, less green space, and greater exposure to heat, or the heat island effect, which I'll talk about a little bit more later. Lower access to grocery stores, also known as supermarket or retail redlining, as well as poor housing conditions, including lead, pest infestation, and poor insulation. Next slide. Next slide. Oh, might be frozen. Okay, there we go. To elaborate a bit more on the heat island effect, we can look at the study by Hoffman et al., which found that in 108 cities, redlined or degraded areas were 2.6 degrees Celsius warmer than non-redlined or A-graded areas. Next slide. And in fact, more locally in Cleveland, Ohio, where many of you are joining from, using the HOLC data from the University of Richmond's data through the Mapping Inequality project, as well as the 2019 US Census, we found that significant disparities exist between A versus degraded areas in racial composition and income. You can see the bar graph on the left shows racial composition in the graded areas, with almost 3/4 of the population in formerly degraded areas being African American, whereas nearly 70% of the population in A-graded areas were white. Income in A-graded areas was almost 3.5 times that of degraded areas, and these patterns were similar for other socioeconomic indicators such as poverty status, use of the Supplemental Nutrition Assistance Program, and educational attainment. Next slide. And in cities like Cleveland or Detroit, this continues to affect communities through poverty, have other ripple effects like food insecurity, property deterioration, and more. And this has shown to have a greater impact among the elderly or adults age 65 and older, as you can see with the increasing poverty rate among the elderly over the years. And that's the graph on the right-hand side. Next slide. And this can also explain some disparities in life expectancy. So some of you might be familiar with this map from the Robert Wood Johnson Foundation. It shows a 12-year difference in life expectancy between St. Clair Superior in Cleveland and Lyndhurst, which is just 8 miles away. And this happens to be spatially consistent with redlined versus non-redlined areas. And now I'll pass it along to India.
Thank you, Gwen. So to gain a better understanding of how historical housing discriminatory policies have played a role in defining disparities in neighborhood environments and health outcomes among residents who are currently living in these graded areas, we conducted a systematic review and a meta-analysis to assess whether health outcomes differ among residents living in historically redlined versus non-redlined neighborhoods. Next slide, please. So we conducted a systematic review following the preferred reporting items for systematic reviews and meta-analysis, or PRISMA for short. We used the PRISMA guidelines and defined our PICO question. And so PICO, standing for population, intervention, or exposure, comparison, group, and outcome, is used to define the 4 elements for our research question. So we defined our population as all US residents. Our exposure was defined as redlined neighborhood or degraded areas defined based on the homeowner's loan corporation grades or redlined index. And then our comparison or control group was defined as residents living in non-redlined neighborhoods. And we covered all health outcomes, including self-reported health outcomes. We included cohort, case control, cross-sectional studies, and excluded any non-US based studies. Next slide, please. We restricted our search to all articles published from January 2010 through October 2020. We started our search with 2010 since this was when the 2 most common types of defining redlining measurements were developed, the HOLC and the redlining index. And we used 4 search databases. We searched PubMed, Cochrane, ScienceDirect, and Web of Science. And the search terms that we used for the exposure included any term related to redlining or historical housing discrimination policies. And then for the outcome, we used any term related to health. Next slide, please. So the systematic review was registered under Prospero, and we conducted a thorough quality assessment of the studies using a method adapted from another systematic review. And the risk of bias was also adapted from other reviews based as well on Cochrane's risk of bias in non-randomized studies of interventions, which is commonly known as the Robbins I index. And for the meta-analysis, we used Revman software. Next slide, please. Thank you. So for results, out of 253 articles, we found 203 were duplicates that were removed, of which 15 full text articles met our eligibility criteria, and 10 articles were included for the systematic review, of which 4 we also included in the meta-analysis. Next slide. Out of the 10 studies that met our inclusion criteria, we found that most articles that assessed redlining in relation to health were based on preterm birth, followed by gun-related injuries and then other health outcomes. The location of the 10 studies were geographically distributed across the East and West Coast, and although we found no studies based on central states of the US. There has been 3 recent papers that are covering more region in the central US, which were not included in this review, but this speaks also to the need to understand the historical context and policies in relation to modern health disparities. Next slide, please. So in summary, based on the 10 articles that assessed health outcomes in relation to redlining exposure, we found that redlining was associated with a 39% increase in asthma emergency department visits, a 3 to 7% increased risk for some types of cancer, but 4 to 18% decrease in other types of cancer, for which Kyung will discuss later in the presentation. There was up to 26% increase in multiple outcomes and 5 to 13 times increase in gun-related injuries. There was a 23 to 57% increase in self-related health, and a meta-analysis showed that 12% increase was associated with preterm births. Next slide, please. For asthma, so the one article that focused on asthma was conducted in several cities in California, and it found that redlining exposure was associated with a 39% increased risk for visiting emergency department visits due to asthma. And based on the maps on the right, if you stop for 5 seconds to observe the maps, you'll notice spatial patterns in redlined areas. So the areas in the red on the top of the maps, and then in darker purple areas representing the asthma ED visits. Next slide, thank you. So potential explanation for these disparities we observed on asthma among red versus non-redlined neighborhoods may include disparities in sources and exposure to environmental pollution, such as landfills and industries and poor housing condition with more dust and pests and less green space and trees, which serve as barriers for air pollution. And now Kyung will share how redlined neighborhoods were associated with cancer.
Thank you, India. So the second article that we found based on the systematic review was focusing on cancer. And this was conducted in 28 municipalities in Massachusetts. And this study found mixed findings based on 4 types of cancer that they examined. Living in redlining neighborhoods, they found 8% increased risk for lung cancer, whereas they found 5% decreased risk for colorectal cancer. And while there might be many explanations explaining the protective effect, one of the discussions or one of the potential reasons for potential protective effect it might not necessarily mean protective effect, but it could be led or the no association could have been led by lack of access to healthcare or health insurance among those who are living in redlining neighborhoods who did not visit or who did not go to screen cancers, which might have shown negative effects, as well as the invasiveness of the screening test that involves for colorectal cancer. So all of that might have factored in factoring in showing the negative or protective effect on cancer for colorectal cancer. Similarly, for breast cancer, living in redlining was associated with 15% increased risk for breast cancer. But again, we found 43% decreased risk for cervical cancer. And similar to colorectal cancer, this could be associated with lack of access to healthcare, insurance, as well as the invasiveness of the screening test. And the the socioeconomics in these 28 municipalities in Massachusetts had very similar trends than in Cleveland and other cities. You can see on the left side, really the good things like home ownership or higher income was higher in A-graded areas or considered the best areas compared to D-graded areas. And the bad things or the things that are, things like percentage below poverty line were higher in D-graded areas compared to other graded areas. The third paper that we found was focusing on looking at multiple chronic diseases, and this was conducted in 9 U.S. cities across in different cities. And overall, this study found positive associations with redlining and health outcomes. However, this study also found negative correlation with cancer, which might be explained by same things, lack of access to healthcare and potential screening or poor screening, invasive screening procedures. This study on that focused on multiple chronic diseases, they just looking at the map, they had, in terms of prevalence of these diseases, they are similar to what India shared. The special patterns are very similar. If you look at redlining neighborhoods in the bottom up, the maps, they are very spatially consistent to the prevalence of chronic diseases that they look at. So the darker colors are showing the prevalence of asthma, diabetes, smoking. So the trends are very similar in terms of how spatially consistent are redlining neighborhoods versus modern health outcomes. And in terms of socioeconomic status, also median income was higher in green graded areas versus red graded areas, and same for percentage of color. It was higher in red graded areas compared to green graded areas. So the trends are similar in all countries or across countries in terms of health outcomes and socioeconomic status. These disparities might be influenced by, in redlining neighborhoods, might be influenced by less promoting amenities like green space, lower access to healthy foods, but higher access to unhealthy foods. And also there might be other, chemicals or other factors that are that people are consuming disproportionately. So people might be exposed to chemicals like endocrine disrupting chemicals that are affecting metabolically or are associated with metabolic syndromes like cardiovascular disease, diabetes, hypertension. And this consumption or disparities in consumption might be influencing these disparities in health outcomes. So with that, I'm going to turn to Gwen, who will explain about gun-related injuries.
Thank you. So there were 2 studies that focused on gun-related injuries. One was conducted in Louisville, Kentucky, and the other in Philadelphia, Pennsylvania. And they found 5 to 13 times increased risk of gun-related injuries or hospitalization in redlined areas versus non-redlined areas. And there is also significant disparities in life expectancy in these 2 cities. Next slide. So the study conducted in Louisville found 5 times increased risk of emergency department visits due to gunshots in redlined areas. So overall, based on the map in the middle, you can see that in general, gunshot-related cases mostly occurred in red or yellow lined areas with some exceptions. And I'll note that the geocoded points here are based on the home address of gunshot victims. Breaking down these gun-related cases, they occurred primarily in C and D graded areas, and nearly 75% of those victims were Black or African Americans, 12% were whites, and 12% other. Next slide, please. For the study in Philadelphia, the authors found up to 13 times greater risk of gun-related injuries in redlined areas. The significantly greater risk also potentially reflects greater population density in Philadelphia versus Louisville, and other factors that accompany larger and more populous cities. Next slide. So moving on to self-rated health, one study examined redlining and self-rated health in Detroit, Michigan, with self-rated health based on questionnaires asking about overall health. And they found increased prevalence of poor self-rated health of 0.23 in individual level analysis and 0.57 in neighborhood level analysis in D versus A graded areas. And this correlation can potentially be explained by the disparities in contextual factors described in previous studies. But also this study was conducted right after the Great Recession that lasted from December 2007 to June 2009, which may have influenced the responses. Next slide, please. So finally, we conducted a meta-analysis on preterm birth outcomes with 4 studies looking at preterm birth and redlining. So pooling the results of these studies, we found 12% increased odds of having preterm birth among mothers living in redlined areas when compared with those living in non-redlined areas. Next slide. One potential environmental explanation for this positive association can stem from what I described earlier, the urban heat island effect. As the recent study by Hoffman et al. Estimated that redline areas tend to be up to 7 degrees Fahrenheit higher than non-redline areas. This can cause dehydration and irregular body temperatures that may induce labor, as well as other physiological effects that affect the placenta. There might be other environmental risk factors too that are more prevalent in redlined areas that can indirectly contribute to preterm birth, including exposure to chemicals, infectious agents, and overall compromised immune system due to nutrient deficiencies. In contrast, a potential explanation for a protective effect that we found in one study by Mendez et al. May stem from social cohesion and community support to women and amongst mothers living in redline neighborhoods. So based on Mendez's study, there are positive things that could potentially be focused on for interventions to reduce adverse health outcomes. And I will note that Mendez used a different metric for redlining than the other 3 studies, which were based on HOLC grade. The Mendez study instead used a redlining index based on more current indicators of mortgage discrimination and segregation. Next slide. And just to highlight, I know there's a lot on there, don't worry about reading it. There was a recent article highlighting how racism may be the only explanation that can link upstream, midstream, and downstream causes. And this was by Braven and colleagues in 2021. Next slide. And the authors emphasized that, quote, racism is the only factor identified that directly or indirectly could explain the racial disparities in the plausible midstream and downstream causes in the observed social patterning. Historical and contemporary systemic racism can explain the racial disparities in socioeconomic opportunities that differentially expose African Americans to lifelong financial stress and associated health harming conditions. Segregation places Black women in stressful surroundings and exposes them to environmental hazards, unquote. And with that, India will wrap up our presentation.
So to conclude and summarize today's presentation, we emphasized 1, that inequality and redlining can affect everyone across all racial, age, and socioeconomic groups, as well as environmentally. And 2, inequities in political power, consumption, and lack in social cohesion and cooperation may contribute to these disparities. 3, racism may explain disparities in social patterning among these neighborhoods. And 4, neighborhood-based interventions or policies can aid in ameliorating these disparities. For future research directions, specifically pertaining to redlining research that could include standardization of redlining measurement, as currently they use different metrics, as Gwen just shared, and then also more research for neighborhood-specific interventions, for example, the effectiveness of support groups for pregnant women comparing redlined versus non-redlined areas, and also policies, for example, to test the effectiveness of health outcomes of placing green space areas and redlined versus non-redlined areas are needed. Next slide. So this systematic review was a collaborative effort of research staff and trainees at the Swetland Center. So that's all our postdocs and predocs, and we would like to thank them for their contributions and multiple feedback on the manuscript that is currently under review. Also, we'd like to acknowledge the funding. So that's FAR, and then Michael and Susan Dell Foundation and the S. Livingston Mather Charitable Trust that supported the training and efforts of some of the co-authors. And thank you so much for listening, and we're happy to answer any questions that you may have or want to further discuss.
Thank you so much for your wonderful presentation. We do have a few questions in the chat box. I'm going to kind of go back through them and just go in order from earliest to most recent questions. So Rachel did ask, and this is referencing, I believe, this slide that had the graphs comparing income inequality and its association with increased CO2 emissions. So Rachel asked, is this because those with higher income are more likely to have access to a vehicle? And are CO2 emissions higher in wealthier communities versus redline communities? So I don't know who would like to take that question and just follow up with that, but that was our first one, it looks like, in the chat.
Yeah, thank you for the great question. I mean, there is wealth accounted for, but in this study, they consider not only, it was based on wealth, but based on area. So they accounted manufacturing, all those things that are in the environment that are related to CO2 emissions. So the income was, a metric, but they accounted for the surrounding emissions. And in this was based on state, but on their paper, if you just go to that paper by Jorgensen, they also, separated by Midwest, East, West. So the differences was different because in the, Midwest, there are more industries, so there are higher emissions. So they, break down all of that, but it was based on several metrics, not only, cars or possessions.
Thank you. So the next one is both a comment and a question. So Mark made a comment. It's regarding, I believe, the next slide after this one that you're on, talking about social, the social inequality degrades the environment. So he made a comment, surprised that social cohesion and trust are lower in segregated communities. Is this compared to suburbs, the population as a whole, or non-segregated communities?
Yeah, thank you for the great question. This is just a theory of how, instead of analysis focusing on certain areas, this is racial segregation or social segregation could lead to more emissions. So yeah, thank you for the question. This is rather than quantifying specific emissions, this is just a theory that explains how that could happen.
Okay, our next question. These are all great questions in the chat. So just to clarify, the study focused just on physical health. There were not any mental or emotional health aspects to this.
Physical health.
Yes, we were focused on physical health outcomes. And so sorry that we didn't get into all of the details of our search criteria, but because we were looking for things that we could have somewhat standardized for the outcomes. And so definitely that would be a good area for future research. And I'm not sure how many studies are currently available looking at the relationship of historical redlining to mental health outcomes or emotional health. But that would certainly be something to include in future research that could tie into this.
Mm-hmm. Yeah, definitely an interesting aspect to consider. Clara asked, what journal is this currently under review in?
It is
Health in Place.
Health in Place.
But it's under review, so
Yep.
can't say anything about it.
Yeah.
Thank you. And then there was also an additional comment from Clara and a question. So she said, first year Cleveland has studied infant mortality, and they posit that it is due to systemic racism in medical care system. How do these findings fit with your meta study?
Yeah, so I can speak to this first, and then if anybody else wants to jump in. So what I would say is that historical redlining is one aspect of a whole system of structural and systemic racism that has been affecting health outcomes historically and continues to today. And so we know that where people live has an effect on their health, but where people live is not the only thing in their lives. And so I would say that this should be looked at sort of in tandem with the things that places like First Year Cleveland, Moms First, Birthing Beautiful Communities are working on. And so that's to say that, you know, addressing historical redlining is one piece of the puzzle. But that, you know, it can't, if we really want to solve these disparities that we see in health across racial groups in places like Cleveland that were historically redlined, then we need to be addressing multiple points of the system simultaneously. And on Kyung or Andy, I don't know if you want to add anything.
And then we do have one more question. So Brenda asked, where did you collect the temperature differences in A grade versus D grade cities? And is this publicly available data?
So yeah, that's from a study, Hoffman et al. We can share. Oh yes. Yeah, so this is from Hoffman et al. 2020. We can share that study with you, Brenda.
Wonderful. And then let's see, we have one from Owuspa. So she said, based on the dates these papers were published and the year the data was collected, did you see any improvements in health conditions in redlined neighborhoods? Is it worsening?
No, things have been fairly static, and I mean that it is hard to say because, you know, so 4 of the studies looked at preterm births, but the other ones were all looking at different health outcomes. So we can't say as much longitudinally for those. But I think that an important thing here is that, you know, redlining was a practice in the 1930s and 1940s, and we're looking at health outcomes today. And so that's a really long time frame, and our study time frame was 10 years, 2010 to 2020. And so I think that, you know, even if we did have longitudinal studies or studies for each of the health outcomes over that period of time, then I wouldn't be surprised if we still weren't seeing differences, because nothing that substantial has been done to address historical redlining in that time that could ameliorate the effects of redlining.
And just to add on to that, Owuswa, this is really, your question relates directly to my dissertation research. So stay tuned on that. I'll be looking to see how redlining and structural racism has an impact on child asthma, and comparing redlined and versus non-redlined neighborhoods, and comparing the lived experiences of Black and white caregivers. So stay tuned for that, and I can give you some updates, hopefully in the spring.
I don't think we have any more questions in the chat. There was a comment, just a suggestion for this audience. It may be helpful to translate 7 degrees Celsius, I think on the slide you're currently on, about the temperature differences to Fahrenheit, if, you know, just as a suggestion, but I don't see it. If anybody else has any other questions, we do have about 10 minutes left, or feel free to unmute if you'd like to ask our presenters any questions, or if you have any comments. We do have some time left.
I just wanted to say I appreciate all your efforts. I found it very interesting. Some parts I knew, and so I appreciate some of the things I didn't know in terms of temperature difference and all of that. So I appreciate your time and efforts in sharing this information with us.
Thank you.
I had a question. You guys did such a nice job of, laying out the evidence, right? That this is a real and it has long-term effects. And I really liked that framing around the upstream, midstream, downstream. I thought that was really helpful. So, and this is an amazing group on the call and other people can hop on, but how do we mobilize these kinds of data? I think and to the point, are we seeing any change? Like, what is the next step for moving this kind of information into action? And I mean, I welcome that from the presenters, but also from people on the call. Because I think sometimes as scientists, we're like, oh, is it real? Like, have we really measured it well enough? And is it true? And can we have confidence? I think we're beyond that, but yet we don't necessarily see I think maybe there's a shift, but not, is it a big enough shift to really get at the long-term impact of something like redlining, the long-term impact of a history of enslavement? What does that look like in terms of, the next 20 years?
I can start by offering one quick thought. I mean, something that I think of with this is, often in system science, we think about unintended consequences of a particular action. And as we are living today, we have, there are many policies, laws that are being enacted. And I wonder, what are some of the unintended consequences that could be coming from those that might have similar effects to what we've been seeing with historic redlining. But the other point is that, to ameliorate the adverse effects of historical redlining, we have to both address sort of the immediate problems now. So with things like preterm birth, India talked about, there are a couple of, neighborhood-based interventions and policies that might help ameliorate disparities. And there are organizations already on the ground that are doing really excellent work around this. Like was mentioned in the Commons, First Year Cleveland, and then I mentioned a couple of others. We have Moms First, Birthing Beautiful Communities right here in the neighborhood. But we also have to recognize that that doesn't dismantle the structures of racism that built historical redlining in the first place and that continue to affect health adversely. And so I guess it's kind of a non-answer, but it's saying that we need to address the problem that exists now, and then we need to address the underlying structures that caused the problem in the first place. But I would also be really interested to hear from the audience about that, if people have, insights into how do you address those underlying structures.
This is Clara Pelfrey. I guess one way to address it is to make this sort of data very, very available and clear to today's current health profession education systems. I mean, not just doctors. We're talking nurses and PA and social work, and probably the social work students get a lot of this, but I think making it part of their curriculum so that they really understand the health disparities and the health inequities stem from historic issues, such as you have pointed out here. And this is a really nice, clear way of doing that. It's hard to find clear information on this to present to students. So this is great.
This is Tiffany. I'm one of the HEMONC fellows at Tosley Cancer Center, and I just wanted to chime in on this aspect.
Tiffany, you went off for a
Yes?
minute. Oh, you went off for a
sorry.
minute.
Okay, am I back?
Yes.
Thank you. I think that another way that we can work on this is to continue to fund research around implicit bias training, but also to test different programs to improve the outcomes of patients as we educate our providers and everyone, you know, who's in a healthcare system. I think that this, over the past couple of years, as we've become increasingly aware about implicit bias and how it can affect the health outcomes of our patients, there is not as much data around what we can specifically do about it at a healthcare and provider level. And so I would love to see more research around this.
Thank you for the wonderful feedback. And we do have an answer to your question, Darcy, in the chat from Rachel. She suggests, I think we need to propose solutions that policymakers and funders can refer to when they have the opportunity to do something, something transformative. So when opportunities like the ARPA, ARPA funding come up, they can tap into new solutions, not the typical 3 things that we do when we don't know what else to do. And then she plugged the menu of actions as an example.
Yeah, I think it kind of gets at this idea of risk, and the things that we do, we know what they produce, but we're really comfortable with them, and we know the people that do it, and we're not sure what it would require to dismantle. I mean, the language that you use, Gwen, dismantle the system. And it might be considered sort of risky in many, many ways, including we don't know if it would work risk. And so I think, like, you know, how do we create a culture that's comfortable with that risk? And that's risk worth taking. And, you know, to your point, Rachel, you know, the same old idea is we know exactly what they will generate. And in an area very close to Swetland Center around food security, if you look at the latest food security data coming out of the USDA, the rate stayed the same for the United States overall. Great news, right? But no, not good news, because if you go in and you look, it actually declined significantly for whites and increased significantly for Blacks during COVID-19 from 19 to 20. But the story, and I've been on a call, you know, is like, oh, well, food security improved or stayed the same. But it, you know, I think we have to keep challenging people to look at the granularity of these findings. And so I appreciate what you guys have done to make it easy to understand. And sometimes maybe people get lost and they don't understand it, but I think making it clear is a helpful step as scientists. But then I think the action side is really important as well. Tim.
I just wanted to compliment our leaders, Kyung, Gwendolyn, and India for the talk. And I think they're too humble, but I think this is the first time I've seen these things summarized in this way. And it's going to be useful for other folks to see it. And it's great to see it organically come out of the audience, that recognition. And to add to Darcy's point, I think, or Clara's point, talking more in healthcare training does seem useful, but it is, we should acknowledge, really hard to do any of this. Like just describing it in the way they did so nicely today is difficult because there's so many factors involved. There's so many potential outcomes. There's so many potential mechanisms, but we got to get started. And this is a great start. Just an opinion, not a question, and a compliment. Thank you for leading this.
Okay, well, are there any other questions or comments from our audience? I know we're coming up here on time, but we do have maybe time for one more, if anybody has a question.
I was just going to comment on the upstream and downstream influences. I really love that slide. I think it's really essential to address those, especially in terms of our healthcare providers and our future providers that are going to be caring for some of these vulnerable populations. So I think in terms of that culture shift that Darcy was talking about, it needs to happen on all levels. So that is our policymakers, that is on our healthcare provider side, and same thing with our activists and our advocates. So they all need to be working together, and it's not in our separate silos, but it's as a unit. So then we can gather these informative conversations like we're having today, but we can gather these ideas from all the different silos and thereby address some of these issues on a daily basis so that our patients aren't sequestered into different groups where they don't actually get that continuation of care, especially when they leave the healthcare centers.
I think that's a really excellent way to end the presentation today. I mean, just pointing that out, that's what you said, there's so key silos, like we are so siloed, let's all work together. And the famous words from John Lewis, let's get into good trouble.
All right, well, I did put the link to where the recording of this seminar will be by the end of the week, as well as the presentation slides that you saw today. So those will be on our website by Friday, hopefully sooner. So I wanted to thank everybody, thank our speakers for the wonderful presentation, and thank all of you for attending and participating. We really appreciate it. And I did link the survey if you're interested and willing to fill it out. It's very brief, just gathering some feedback about our seminar series. So everybody have a wonderful Tuesday and a great rest of your week. Bye.